My name's Marty. I'm here filling in for Dr. Themis Kyriakides today. Yesterday we talked about skin. Now we're talking about next generation matrix for bone repair. So we already had a really great introduction on osteoporosis. Someday this slide will go forward. We already know it's a very predominant condition that predominantly affects women. Is this the laser pointer? Oh, there we go. Oh my gosh, so far ahead. All right. Osteoporosis drives a majority of fractures in women over 50. Osteoporotic bone heals very poorly, leading to non-union bones, repeat fractures, specifically fragility fractures. Current grafts fail due to a weak, low-quality bone environment, and even though this is a massive problem, it's an underserved $3 billion opportunity. A few quick facts: that 50% of women over 50 will experience a fracture. 80% of osteoporosis patients are women. There's 300,000 hip fractures a year in the US, and there's a 30% one-year mortality after these hip fractures, so it's a severe issue. We're developing next-generation matrix to fix this. This ECM, it's thrombospondin 2 deficient ECM. So thrombospondin 2 is a natural inhibitor to cell infiltration and angiogenesis. So if you knock out this gene, you end up promoting those pathways, promoting infiltration and angiogenesis. This can lead to pro-healing regeneration and functional tissue restoration. So where biology fails, we have an engineered tissue engineering solution. What does this look like as a product? Well, we've successfully created a bone ECM hydrogel. You start out with genetically modified bone, and just like you wash dirt out of your clothes, you can wash the minerals and cells out of these bones to leave behind the extracellular matrix or the protein scaffold and use that as a therapeutic. You can then solubilize it into a liquid form and then inject or mold this into a hydrogel to promote bone regeneration. So here's what it looks like under the scanning electron microscopy. It's a nanofibrous matrix reminiscent of your native ECM. And here in red, we show vascular cells grow readily into this matrix. We've shown proof of concept in rat skull defect models. When there's no implant after removing a chunk of the skull, there's no healing. There's standard ECM. You see a little bit of healing. This is reminiscent of products you see on the market, or wild type, not genetically modified ECM. And then when we use our genetically modified ECM, our TSP2 knockout, you see significantly more bone formation. Furthermore, under the microscope, you see a lot of vascular ingrowth, as indicated by the red and green staining in the lower right. We expect to be a best-in-class for a bone graft landscape. Most of the products out there are allografts, in other words, donor-derived bone products, or synthetic. Think of things like polymers, or autografts, taking bone from another part of your body and implanting it where these fractures occur. We think we can achieve the right balance of manufacturing scalability as well as bioactive and regeneration potential. Regarding IP, we have a robust and enforceable portfolio that's the intersection of composition, methods, and source material. At Yale, we have issued patents on composition and methods for therapeutic use, as well as we have our partners Recombinetics, which has the source material production on our genetically modified animals. From biology to business, this has been a problem that Dr. Themis Kyriakides has been studying for over 2 decades across this TSP2 knockout mechanism. He has multiple papers in the space. More recently, with our industrial collaborators, we've completed a phase 1 SBIR to generate genetically modified pigs as a commercial source of material. More recently, we've incorporated the company to take over and commercialize these products. Driving success, this is our launch team. We have a multidisciplinary team covering engineering, materials, as well as in the clinic, as well as we have ECM experts on our team. We also have additional strategic as well as regulatory and manufacturing partners. We have a streamlined path to market. We think this is going to be a Class 2 medical device. We think it can be a 510K pathway, but we're not ruling out the de novo route. Where we've generated a product, we have done small scale in the research setting, but really we want to get this ready for design for manufacturing to hand off to a manufacturing partner to take over and scale up, as well as to investigate this in other preclinical models. We think our beachhead market is going to be in vertebral compression fractures, but there's also a whole host of other indications we can go into for bone regeneration. There's a strong market appetite for M&A and licensing in the space. There's been some recent acquisitions nearing over $500 million. Most of those are driven by commercial annual revenue. And then what we propose to do with these activities, of course, is to further investigate the manufacturing process. The processing is not trivial. We want to scale up and get final finished protocols in place to hand over to a manufacturing partner. With that, I'm happy to take questions. Thank you for your time.
Thank you, Marty. Right on time. It's not easy to finish in 5 minutes. Carla?
Yes. Really brilliant idea. Thank you for your presentation. Can you talk me through this idea of taking these tissues? I'm always worried about when you're decellularizing, what you're decellularizing. What is going to be the immune response when you're putting that hydrogel now into a human?
Yeah, that's a great question. With these animal-derived tissues, you decellularize it, so you're stripping out of the cells, which are a major source of the immunogenicity. However, the proteins are more conserved across species, but there is an immune response, but that's part of the healing response as well. So in addition to vascular cells and fibroblasts or osteoblasts growing into this, you can get immune cells in there that help break down this ECM, but then you rebuild it into your own native healthy tissue. So it's part of the healing process.
Okay, and have you guys shown this preclinically already, that this is the case?
With immunogenicity?
Yeah.
So yeah, we've studied this in multiple injury models, ranging from skin to vascular, muscle, and bone. So we've seen a lot of this immune response across indications.
What are your expectations for turnover of the hydrogel? The bone is a highly active, remodeled system. So curious what your expectations are for how long this will be durable.
Yeah. These hydrogels are meant to be biodegradable, so they're not meant to last forever. But what we've seen preclinically is typically a couple weeks. I know in the subcutaneous environment, you usually see the hydrogel fully gone or degraded in about 4 to 6 weeks. It depends on the bone and the immune response of the patient. So a more aggressive immune response will break it down faster.
So to follow up on Ivanka's question then, is the idea that once the hydrogel degrades, you will have some understanding of the percentage of bone that was reformed, and then someone will need to come back in and get more hydrogel? Or I think similarly to some of the questions we asked the previous presenter, what does this actually look like, for a patient and or a clinician to use?
Yeah, it's going to be a trade-off of degradation of the hydrogel and then rebuilding of the bone. So in our preclinical data with these skull defect models, these are a single application of the hydrogel. So ideally in the clinic, it would also be a single application, but that's something we'll investigate in our phase 1 trials or our early feasibility studies. So we'll line it up with CT imaging to confirm.
Great. Thank you
Thank you
for
very
all
much.
the wonderful questions.